Thank you very much for that introduction. We have a fair amount of material to get through here, and we know that the probably the most important part of these presentations is the discussion at the end. So I want to get right into it. As you can see here, as already discussed, Dr. Ong is going to be presenting the toolkit that we've created for helping people think through issues related to implementing identity management, some real world implementations. And then I'm going to talk about some of the non-technical issues that are important to consider in patient matching. So that's the agenda, basically. So problem statement, why are we talking today? So everybody knows that there are technical issues related to implementing patient matching identity management systems, but there's also non-technical elements, as many of you are aware, data governance, change management, et cetera. And so we want to talk about those specifically in the context of patient matching to give you a flavor, a feel for what the process looks like, what the approach can look like. So that's our general overview. And with that, I'm going to hand it over to Tone to take it away.
Good morning, good afternoon, good evening, everybody. My name is Ton Ong, and I'm very happy to be here today to talk about the work that we've been doing in the data use community to create, what we call the patient identity management toolkit. Really the object, the goal of this toolkit is to create a share tool or knowledge that all the participants in the data use community and the larger community can participate in when it comes to patient identity management. So in this toolkit right now, we have two different modules drafted. So I want to say that this is a work in progress. So everybody's input will be contributing to development of making this the tool that we are developing better. Right now we have the matching module and the biometrics module, and I included the short URL link here that you can take a screenshot of and go to and check out the content that we currently have in each of these modules. And so for my part of the presentation, I'm going to quickly go over the content of each of these modules that we have in the toolkit. Okay, so the matching module is about describing the process for conducting matching patient level records across health data sets, health-related data sets. And the intended audience would be the implementers, the data analysts and the developers, program officer who are interested in conducting patient matching. In this module, we describe the key phases of the process of patient matching, and I'm going to go over what these phases are about on a later slide. But really it's described the process to evaluate data quality. What variable you're gonna select. What aspect of the data that you need to care about when you intend to use that data for patient matching. Understanding the different matching strategies, as well as the advantages and disadvantages of each strategy. And then how to evaluate the performance of the matching algorithm. And then the rationale for monitoring and evaluating the ongoing process of matching. So, even for people who make their living doing patient matchings, the process has many different aspects and details that you need to be aware of. And so people tend to sometimes overlook or forget about some of the important components of that process. So the objective of this module is to synthesize, these components, so people can rely on, a starter, right, or somebody who do it in a regular basis, but need to be reminded of these components, can always go back to and use the content to to conduct patient matching in their system. So the three phases in the are being described in the three module include the first phase of determining the variables to be used in the linkage process, and how to characterize or understand the quality of these identifiers. So based upon that, the next step is to address and understand the limitations of the source of the data, and then use that as information to select the optimal algorithm. Phase two is about the actual implementation of the matching algorithm, and establishing the adjudication process to evaluate the performance of the solution. And then so the steps in this phase involve determining who's going to do what. And so in this process, usually we usually have a leader who responsible for overlooking the entire process, and then you have software, the people who are responsible for software development, as well as conducting the linkage and performing linkage adjudication, as also data, ensuring the quality of the linkage data. And then in phase three, we are looking into maintaining the linkage system and refining, the performance, as needed. So that I went over that module very quickly to make sure that we have room for discussion later on. But happy to expand on any of the components that that I just presented. The second module in the toolkit is the biometrics module. And the goal of this module is to highlight consideration to implement biometrics to support patient identity management. And again, this is intended for program implementers, the IT managers and developers. The objectives of the biometric module is to introduce the biometric technology being used in patient matching, and to talk about the accuracy, efficiency, of using biometrics information, as well as to discuss the limitations and the risk and all the concerns related to using biometrics information for this purpose. We also talk about the steps involved in implementing biometric system, and talk about the current trends and future development of using biometrics in healthcare in general. So the overall objective of patient identity management is to match patient and to identify the records or the information that belong to an individual patient. And so biometrics, as we know, has a unique advantage for that purpose, because of the uniqueness of, for example, the fingerprint, the permanence of the information. Your fingerprint rarely change over time. Maybe when kids grow up, there's a little bit of change in their fingerprint. But among adults, that's rarely the case. And then, but there's other considerations, such as people who lack fingerprints or have their the skin on their fingertip damaged and things like that. But in general, biometrics information is usually reliable and consistent over time, so that it has a unique advantage in patient identity management. And then we also talk a lot about the advantages and disadvantages of different biometrics modalities, right? What is the drawbacks and the benefits of using fingerprints or facial recognition, or other biometrics features that you can use. And then we also talk about accuracy, the accuracy and efficiency. As we know, as we all know, it's not very efficient to primarily use biometrics at the, for example, the national level. That's very, very large scale. So so we need extensive consideration when we try to use biometrics at at scale. We also talk about privacy and security. Biometrics information is unique. However, it cannot be changed, right? So privacy, protecting the privacy of biometrics information is important, because if that is jeopardized, then it might have very serious consequences. There's also legal and ethical aspect of that, to make sure that there's no discrimination or anything like that related to using biometrics information, as well as adequate consent from the patients to make sure that they are aware that their information is being used for that purpose. So I'm again apologize for moving so quickly, because we have a lot to talk about, and then so we can extend on this on the discussion portion of this presentation. Some of the use cases that we learn about from countries in the open HIA community, as well as the data use community. So the first case is in Kenya, and the objective of the PMI in Kenya is to make sure that this system can support a continuum of care, and then to make sure to improve the safety of care delivery in this process. For example, to avoid unnecessary or repeat procedures in clinics, and support scheduling, billing, insurance procedure, as well as to support public health surveillance system, and not double counting patient in that data. As with many other countries, the challenges they are facing include systems, like disparate health information system, not using the same technology, including some of the system using paper-based documentation, and then the intention to implement or use biometric system faced with high cost problem. And then there's also a problem with the lack of awareness of the role of having a unique identification in that process. And so the solution that Kenya is looking into, or already implemented, is to use the national IDs based on government issues identifiers, as well as trying to establish the linkage, not just at the national level, but also at the local level, and establish that communication between the local system and the national patient registry. They also work very hard on, gaining support, from the leadership, as well as the community, to get buy-ins for their effort to create that unique identifiers for patients. In case of Nigeria, their plan is to create a centralized system where they can collect and store all the fingerprints of the majority of the population, and then use that infrastructure to support patient registration, as well as creating the longitudinal data of health records in the country. And then, so, the idea is, for patients who seek care, they can provide their biometrics information with they will be identified in the system. Many challenges, as I mentioned, with fingerprint data, the quality of the fingerprint, system interoperability. Many systems have problems communicating with each other. There's a huge concern with data security and privacy, as you understand. And then because they are trying to do this at the national level, so there's also concern with scalability and, adaptability as well. Some of the problem with using this system widely is, to make sure that they can uniquely identify, specific group of patients, especially infants, and, patients with disabilities, when they have damaged fingerprint or, not enough fingers to be captured. So the solution is to capture as many fingers as possible. Ideally, they want to capture all fingers, all 10 fingers every time. Rely on standard format and protocols as much as possible, using encrypted data, and then again, because when so the fingerprint and the biometrics information will be captured at the local level, but then all of the data will be then, transported to the national registry, where there's, computing resources and all that can help with the matching and the duplication process. So there are amazing case studies that we learn about from the community. So this is the link that will lead you to more case studies that we learn from, and so you can go to this website and learn more from these cases. I think that's the end of my part, and I'm going to hand it over to Sean to talk about change and governance.
Great, thanks, Tone. You did a great job of getting through that material. So thank you for that. I'm here to talk about change management, sort of the softer elements of this work. Part of the reason that we're discussing this is we understand from many, not only folks in AHIN, but also in the work we've been doing through the data use community work that Tone has described. Governance and change management are issues that continue to arise repeatedly. And what I want to start with is there is no one-size-fits-all approach to governance and change management, because typically these are issues that pertain to culture, to local political and social environments, because identity management is personal, right? Identity is is viewed in very different ways in different culture. And so we need to understand how to manage identity in different cultures. And so that's why governance is a process that intended to adapt to the needs, the priorities, the expectations of a particular culture. And also, of course, managing a process, a change process, is very important as well. And so I'm going to talk a little bit about those items, and then we can move forward into discussion. Sometimes you may be surprised about who is impacted in a particular IT project, particularly patient matching. This issue in different countries touches on privacy advocates, security advocates. It touches on industry. So if there are existing solutions in place, there's a potential for displacement of solutions and making sure that the impacted individuals are involved. You have to think about the whole process that's going to be impacted. So patient matching, patient identity management begins at patient registration. And so patient registration clerks, who often are some of the lowest paid, receive the least training, are the most important to this process. So making sure that you have the waterfront of stakeholders involved in the process is going to be very important. And so we're talking about everyone from registration clerks to policymakers. We need to make sure that those stakeholder groups are included. In fact, where I work in the United States, we have the American Health Information Management Association, which is an association of health data workers, including registration clerks in the United States, who take part in patient matching. And again, I'm going to talk about general principles. Stating very clearly, or as clearly as possible, why identity management, why implementing a new system is super important. And one of the reasons we offer when talking about identity management is, for the obvious reasons of being able to bring together data so that charts are not fragmented, so that clinicians can take better care of patients. But summarizing all of that down, good patient matching improves patient safety. And so being able to very clearly describe why this is important and understand what role people have in achieving those objectives. So how can I make sure that better decisions are made about patients? How can I make sure that the proper treatments are assigned to the proper person? How can I ensure that the care process is maximized for a particular person? Patient matching is key to that. Let's move on to the next piece here. Robust governance framework. All I'll say about this is governance cannot be overlooked in planning an identity management deployment. You, again, need to make sure that there's appropriate focus, not only on the technical, but on the organizational and interactional aspect of the project as well. So we often recommend, a steering committee to oversee the project. Project management is often involved in subject matter expert groups. And by the way, when implementing a patient identity management system nationally, often that governance process is aligned with identity management, and the national rollout writ large are often overlapping or tightly aligned processes. So the governance process for an overall eHealth network is tightly aligned, maybe overlapping with the identity management work. Communicate early and often is the key. Understanding the messaging to different stakeholder groups is very important. Here in the U.S., we have been advocating. The United States is one of the last developed countries in the world without a unique patient identifier. I've been working with Congress and other political stakeholders for many years, and you have to communicate to industry partners. You have to communicate with policymakers. You have to communicate with stakeholder interest groups, industry groups, consumer groups to help them understand why this process is important, necessary, and helpful. So again, very important at that national level. Training, being able to educate and train, ensure that you have workforce capacity, that you have the capability within the system to manage all of these items. And I, I know that what I'm describing is very high level, but these principles need to be adapted to particular circumstances. So the training and education in the Philippines may not be what's needed for training and education in Vietnam or other places. So there's an adaptation of this, but these are really checklists of elements that need to be incorporated into your system. Change advocacy. So having champions, having advocates whose job is to advocate and make sure that this work continues to go well is super important. So having both peers and leaders involved helps to maximize the likelihood of success. Piloting, I think, is a very to most seasoned health information professionals. Often piloting a process before a large cutover is helpful in smoke testing, getting the bugs out, making sure that all elements have been addressed. That is also important. Feedback mechanisms, being able to understand where things are working well and where they're not is very important. So being able to provide that feedback element is very important. Risk management, identifying risks, including the data breaches and privacy concerns is important. Certainly, managing patient identity is managing elements of data that are very personal and often treated as confidential, and so ensuring that the systems that leverage that are safe and secure is important. This is something I want to emphasize. Often systems are deployed without good performance metrics, without good monitoring tools. Tone talked about measuring the performance, the accuracy of a matching system. In addition to matching system performance from an accuracy perspective, understanding how efficient the system is, how responsive the system is, understanding the volume and scale. I see that there's some discussions about scale in the chat right now, but being able to measure on a regular basis the process metrics for the system. How many unmatched patients? How many unadjudicated records? What is the effort required in that space? What is the overall cost of the system? Monitoring those issues is important. And there are myriad performance metrics that can be contemplated, but it's super important to be able to answer the question, have we been successful? How do we know? Because we're measuring the outcomes of the system. Data governance. So very quickly, governance, as I mentioned, is very much a part of change management. If we want a successful patient matching system, then we need to ensure that that we have good data quality, that the system that we're building is interoperable, or that interoperability is available, and data governance also enables patient safety, as I've mentioned before. So these are the reasons why. So when people ask, why is governance important, specifically to identity management, these are some of the top priority reasons why governance should be an important part of your process. And these are the important elements. I'm not going to read all of the words on this slide, but these are the typical elements we see in a governance framework. And you'll note that these closely align with change management as well, because change management and governance are two very aligned concepts. Change management tends to be a process that's focused on initially with ongoing attention. Governance never ends. Governance is an ongoing process to ensure that a system continues to work well. But again, these are some of the elements, and I know the AHIN team, and I know many of the educational tools that you all have leveraged and are well versed in governance. So I'm not going to belabor this. There are steps for deploying governance, particularly in IT and patient management. Again, they align well with general governance principles. These are all ensure security is super important with this work. Interoperability, of course, is necessary to cover large groups, and stakeholder engagement and evaluation. So I will leave you with, in terms of governance and change management, make sure that you're monitoring what you're doing and have good concrete metrics, because they'll help not only help you know how you're doing, but they'll also help you justify to others why you're doing what you're doing. So with that, now I think I'm at the last slide. All right, great. Thank you very much. So we came in at 8:41, so 1 minute. So I know that we covered a lot of ground here today, and I know that we'll have a reaction and then question and answers. So happy to go into any additional detail that folks would want. Thank you.
Yes, thank you for that presentation, Dr. Tone and Dr. Sean. We also invited the reactor for tonight's webinar. I would like to introduce Mr. Felipe P. Canlas, Executive Director of the Wireless Access for Health Initiative, or WA, which is a pioneer EMR service provider in the Philippines. So over to you, Sir Pei.
Thank you, Cha. Hello, Sean. Hello, Ong. So first, thank you very much for a very comprehensive presentation. So we are an implementer of HIS or EMR here in the Philippines. We are now covering almost 300 health facilities, primarily public primary healthcare units, and we work primarily also with local government units from provinces, cities, and municipalities. So my first question would be, of course, you can address this later, is are the toolkits free to use, and how can we get access or copy? And if we ever implement or strategize using the toolkits, can we get support from your team, if ever? So outside of these questions, I must also commend the speakers for a very comprehensive, straightforward, and very doable strategies that are presented in the toolkit. But if I may also refer to our experiences here in the Philippines, if I may quote Mike Tyson, no plan survives, and no plan. Everybody has a plan until one gets punched in the mouth, something like that. So I believe Sean already mentioned this, right? I mean, plans and strategies are wonderful, even a toolkit, but until we get punched by realities on the ground, then we may or we may never know what if they will really work. So having said that, it is very important to learn, and I hope there are follow-up sessions about Nigeria and Kenya. I was really looking forward with those experiences so that we can learn more and choose which one that can be applied here in the Philippines and in Asia. So, but in general, as described by Ong, the cases for Nigeria and Kenya are very similar with Asia in general, in particular the issues on governance, interoperability, and ownership. So, outside of that, I would also react on what Sean said about the importance of culture and context and communication. I mean, systems and softwares always deal mostly with black and white, zeros and ones, but just to emphasize, they do not operate in a vacuum. Context is very important, and Sean mentioned this, and that no one size fits all. And I especially love this, Sean, that identity is very personal. It is personal, really. So and that's why I think the highlight of the discussion for me would be how Sean put very particular emphasis on governance framework. Here in the Philippines and during many AHIN conferences and webinars, we are finding out that nothing is get done right for the right reason and for the right persons without establishing a governance structure anchored on transparency and accountability. So I think that's where everything should start when it comes to digital health and in particular about patient identity management. I would also like to special mention the highlighting of a communication strategy. I think that is also very important, context-wise, an audience-targeted approach based on the needs and cultural backgrounds of the stakeholders will play a very big role in implementing the patient identity management system. So as for the realities on the ground in the Philippines, and probably it's applicable to in some countries in Southeast Asia, number one for us is culture. Of course, Sean mentioned this. We have history of martial law, and anything that has something to do with fingerprinting, Sean, is actually frowned upon, and we have this association about the blue state. Yeah, so maybe our neighbors from Southeast Asia, whom had also some share of the police state, can also chime in later. And then, of course, there are also the challenges of fingerprinting, or at least the facial recognition biometric for our indigenous people, who are the most needy in terms of public health care. So it was already mentioned, the infants and children, the challenges. So, and then for us, we also have trust issues. At least majority of the population. It was mentioned in the chat, for example, that can patient identity management, or in this case, fingerprinting or the fingerprints can be the single source of truth. I think normative-wise, we can also ask, should they be? So, and then on another level, can government competently and securely handle patient identity information? Here in the Philippines, we have two major breaches, for example, in the past 6 months for our two national health government agencies. So the trust level as of now is really low. And then finally, for our experiences, decentralization. Under our universal healthcare law and the 1991 law, the primary handler and executioner of health in the Philippines would be the local government unit. So where would they fit in the midst of this patient identity management strategizing and implementation? So for example, some provinces and cities that we work with already have their own biometrics and patient matching identification systems. And many of these, upon initial consultation, do not want to just give this up in favor of let's say, a national effort towards PIM. So, but closing, for us providers and implementers on the ground, we just want to get things decided so that things get done. For our regulators, for example, like the MOH, it makes our job easier and our costs more affordable if they can already arrived at a decision on how to approach PIM. As of now, we're still waiting here in the Philippines how to go about this one. I think they should not aspire for perfection, as already mentioned. We just want a North Star so that we can be guided and look at that North Star and know where we are going 5 or 10 years from now. Our dictum implementers here in the Philippines would be, we learn as we do, we just adapt as we go. And a governance framework, a North Star, will be very helpful for us in terms of going about how to do patient identity management. Thank you very much.
Great. Yeah. Before we answer that, I just want to say the comment section is amazing. I think there's enough material in there to have another hour discussion on all of these issues. With 9 minutes left, I think we have, we'll be able to get to some things, but I don't think we're going to be able to get to all. Tone, do you want to take the toolkit question?
Yeah, so the toolkit is freely available. It's open to community. You can use the link that was provided to provide your feedback. And back to the comment earlier about the actual situation on the ground. That's why we need to that's why we open the toolkits up to the wider community, so we can learn from you, so we can address as many cases as possible. Because again, as I mentioned, the ultimate objective of the toolkit is to provide something useful to the community, so you can rely on, you can go back to, you can improve upon to implement your PIM. And I saw one of the many comments in the chat about the Asia and European case studies. We love to enrich our repository of case studies with additional cases. But right now the most of the cases are from Africa, and so if you are willing to present, to talk about your case study for the benefit of the community, I think that's going to be fantastic. So that's my response, Sean.
Yeah, excellent. The toolkit, it was born out of community experience. We have different members presenting on how they're thinking about. They might be at the beginning, still thinking about it. Some have implemented, but we're learning from that. And based on that, we've identified the themes and the elements, and that goes into the toolkit. So Tone and I, primarily Tone, have written the toolkit based on what we're hearing and learning. And so the more we can hear about what's important, the more we can incorporate and make sure that those principles, those approaches are there. I do see, I think Bunchai, you have your hand up. It's good to see you, friend.
Yeah, thank you, Sean. A long time no see, and thank you, everyone. I would like to emphasize the point that you give. To me, I think the toolkits, the technical, it easy, and it already study a lot. And I wonder why Philippines don't follow the India ATA models, just trying to work up on the ground. And I think India, especially in Asia, we have a kind of not culturally much concern about identity as in the US and the Europeans. So the way that we create the MPI, to create MPI with many stakeholders, power play who are going to do this kind of the registry, looking at the use case, the benefit that will give to the individual to be identified like ATA in the India. That what my comment on that. I have question for you, Sean, that you are the champion on the Indiana Health Information Exchange, and we know that US has been promulgate HIPAA law since 1996, and they issue that they should have the personal identity and provider identity. But the personal identity, you said for yourself, you work for at least 20-30 years with the Congress, but the culture of not want to be identified, that make it is not possible, like not India or Sri Lanka or Thailand or Japan that have one's identity. But you still can be working on the health information exchange in the Indiana. Could you give a little bit 1 or 2 minutes to describe how would you do that in the
Sure.
context that is not possible to get people to have the national MPI or registry. Over. Thank you.
Yeah, you bet. No, great question. So you're right. In the absence of a national unique patient identifier, we have patient matching algorithms and that use demographic data, identifying data that are routinely captured in the course of care. And so right now we don't have that national identity strategy. We've already written one report to Congress, and we're about to start working on a second one. I think someday the United States will probably have something like a national ID. But right now, what can we do? You always want to try to do the best you can with what you have. And what we have right now are demographic identifiers. And so what we try to do is optimize those using a variety of algorithms. Now, we know in the United States right now that there are lots of different algorithms and methods for matching patients. And we know very little about how well those production systems are working writ large. Vendors don't produce great accuracy measurements and don't produce lots of descriptions about how their matching systems work, because that's proprietary and they don't want to give that away. But what we're starting to see from a policy and national level is a push for the ability to evaluate, measure the performance of commercial matching systems. And I think if you shine the light on these systems, either people are going to say, you know what, matching systems are good enough, let's stop worrying about this national ID. Or, and I think this is more likely, people are going to start to say, wait a minute, there are segments of our population that aren't well identified, like children, like women who change their name when they get married. There are lots of homeless people. There's lots of segments of the population that aren't well matched with algorithms. And so that's where we are today. That's the state of the art. We have a matching system in Indiana that has been measured multiple times. We've got over 99% positive predictive value and over 95% sensitivity. We measure it and we tell everybody about it because we want people to be comfortable with it. Our governance committee for the HIE understands very clearly how matching is done, how it works, so we have buy-in. So that's how we do it in Indiana.
Thank you. I will not keep another people, but just a quick question to you and for the audience that you see matching with all the variable is a big overhead on the identify people. Can this be the issue that we propose to the stakeholder, that why don't we come across this hurdle, not give the money to all the matching algorithm, something like that. And this can be kind of persuade people to kind of the second thinking about have the way to identify people, like in Aadhaar in India. And right now you see the face recognition technology is very, very cheap and it's very, very good. We don't need the iris anymore. Why don't we utilizing those? It come to the governance things, that how we can agree on to get the
I agree. Good issue. Like I said, I think we've got at least another hour of content here. So
okay, thank
Sean, Toan, and Pei, thank you very much. We've reached the top of the hour, but we have a lot of unanswered questions. So my proposal, and if you agree, we'll hold another one, a follow-up, not in the next week because we have some sessions already scheduled, but definitely, I think we need to have another session so that we can have better interactions. Also, belated happy birthday to Dr. Bunchay, April 23. And thank you to everyone for participating tonight. Sean, Tuan, are we okay with a follow-up session? And maybe we can invite a larger group?
Sure.
good with it.
Happy. Yeah. Happy to do so.
Thank you very much, everyone.
Bye.
Sean, Juan, we'll have a follow-up.
Thank you.
Good
All
night,
right. Take care.
everyone. Good night.
Bye
Take
now.
care. Bye.